Oh, good afternoon. Welcome to Jefferson County Public Hospital District Number 2 Board of Commissioners meeting, regular session on Wednesday, August 26, 2020. Under this is a COVID-19 notice. No in-person attendance allowed pursuant to Governor Inslee's Proclamation 2028. To attend the meeting, anyone that is outside of this broadcast, there is a phone number on the agenda that tells you how to access it. We will have no live public comment, and in lieu of that, the public may comment on the agenda item or any other matter related to the district via a letter addressed to the commissioners at our address listed on the agenda. Without further ado, we will go into the motion to approve the agenda. May I have a motion?
So moved.
Second?
So moved. Second.
All in favor, say aye.
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 All right, agenda is approved. So we will go into our education topic at this point, and that will conclude at 3:15, and we will have a 15-minute break and return for our business meeting at 3:30. So without further ado, we welcome Jen Wharton, our Chief Ambulatory and Medical Group Officer, and Dr. Steve Butterfield, Chief Medical Officer, Medical Group, for a medical group update. Thank you.
Yeah, great. Thank you, Jill. Thanks, and thanks everybody for having us. We just wanted to share with you some of the updates that we were going through in the medical group, both from a clinical and programmatic perspective. And the last time we were together and share information that has changed since then. So we'll kind of go through, the last time we were together was April of 2019, and I thought we'd kind of go through kind of where we were at that point and what has changed since then, and share with you what we have contributed to the community and the organization from the medical group side when we went through our pandemic pause, and then talk a little bit about future state and then the development of our multi-specialty medical group as well.
Before we get started, can we just do a quick sound check? Because Jen and I are actually sharing a room. Does it sound okay to you guys? Not too echoey or anything?
Sounds fine.
Okay, perfect.
Sounds good
Great.
to me.
We're also figuring out our AV.
And if you have any questions, feel free to speak up along the way. Very informal, so feel free to chime in, interrupt, whatever works. So last time we were together, had just joined from the medical group, started out as primary care and cardiology, and just formed our multi-specialty medical group. And in there we joined, the medical group was orthopedics, dermatology, general surgery, and dental. We hadn't even opened our dental clinic yet the last time we spoke. And then of course, cardiology, and then our women's services as well. And our support team consists of our care transformation team, our population health team. We have a data analytics group, as well as our care coordinators and care navigators that help out with care. And then, so we haven't actually added any additional services to the medical group, but what we have added are additional clinical services to those areas. In orthopedics, since the last time we spoke, we started robotic assisted total joint program. We had the addition of Dr. Meyerson, our hand and plastic physician, as well as the addition of a per diem orthopedic surgeon that got emergency credentialing, but is going to stay on with us through normal credentialing as well, and be part of the team as needed. And then in dermatology, they have been implementing their photodynamic light therapy, as well as their whole body ultraviolet UVB therapy as well. New changes in general surgery was thyroidectomy. And in primary care, we added 3 additional primary care providers, an additional behavioral health provider. And we entered into a program with AIMS, which we've been working on with our behavioral health integration, but we got a grant of about $250,000 to further integrate that program into our primary care team. So that's currently in progress as well. And then we opened up, as you guys know, our dental clinic, and we actually hired another dentist that will start around February of next year. So we're pretty excited about that. And in cardiology, we added an advanced practice provider, an addition of several cardiac RNs to help out with some redundancy of services and more increased robust support for our providers in cardiology. Cardiac rehab, and as well as stress echocardiogram and transesophageal echocardiogram as well. And then in women's health, I think that you guys have all heard, we've had some great changes take place. Dr. Hoffman, as you guys know, went to Seattle to work as kind of an intensivist. And then so we started the recruitment process for a new OBGYN. And I believe in hiring, prior to that, I think the recruitment process was upwards of 3+ more years to find an OBGYN. So we have had some locums help in the meantime, and we were fortunate enough to find 2 really great OBGYNs, which we didn't expect, and which is a great opportunity for us to really think about what are we doing with this service line. And we all know that one physician does not a service line make. So do we have the ability to hire 2? So we worked with Jody Corona, who did a lot of the work for our master site planning in terms of market share. And she helped us to work through some market share for GYN surgical services. And come to find out, we only have about 20% of the GYN surgical services within our county. And of those list of services, I ran those past Dr. Christine Skorberg, who is going to be our medical director of the Women's Health Clinic. And she said, hey, yeah, I do all of these. And so does Dr. Luckman as well. So what we would like to do is really work on growing, expanding that GYN surgical services, really gaining the trust of the community, and so that they can continue to keep that type of care local as well. So we're pretty excited about the 2 of them coming on board. They both start November 9th. Dr. Skorberg is going to be working with me starting next month to help build a strategy plan for the development of that clinic. So I'm pretty excited. And once they get their clinical feet underneath them, we'll start strategy discussions with our FPOBs in terms of, where do we want to advance and enhance our women's health service line.
Yeah, I just wanted to add a little bit of additional information about Christine and Asif. As Jen said, in looking back in the history of recruiting gynecologists here, it took about 3 years to recruit Dr. Hoffman, and what we really didn't want to do was to be desperate and recruit someone that wasn't a great fit for this organization, and we actually turned a couple of candidates down, people that we interviewed on site, and so when we at nearly the same time got CVs from Christine and Asif, and I had the opportunity to talk with them, we were just really blown away at the opportunity to be able to add both of them, and really they're such a complement to each other. Dr. Skorberg, is a fellow of the American College of Gynecology, is like 30 years in practice. Dr. Luckman has just finished his fellowship, but we thought that they really complemented each other so well, and that it was this 1 + 1 was much greater than 2, and I really appreciate the organization's ability to kind of have the vision to take a calculated risk and really try to build this program. And Sarah's been with us for about a year. Some of you might know her. She worked in public health before, and she's just great. And then I want to make sure we don't forget to mention Jane Albee, who has really been our rock for that service for the past few years. So we're excited.
Yeah, great.
So may I ask if
Sure.
Jane is still with us?
She is. Yep.
Good.
Yep.
Great.
And Jane, and I would say, Jane and Sarah were integral in the the interview process with Dr. Skorberg and Dr. Luckman, as were our FPOB group, and we really wanted to make sure that the people we were bringing in felt like a good fit for what this organization needed. And really, before we even introduced the idea of, could we maybe hire both of these guys, the conversations we had in these interviews were like, gosh, I wish we could hire both of them, from the providers that were part of that interview. So it was really great to be able to go back to them and be like, well, yeah, we're going to do that.
Great.
It's really nice to have one with a lot of experience, and then Dr. Lugman coming up can learn a lot from her too. So that sounds like a really good idea, good plan.
Yeah, great. So we were moving right along in terms of how best to grow and expand our medical group when March came upon us and we took a pandemic pause. And so kind of changed, as for everybody, the direction of what we were focusing on. And Dr. Butterfield is going to kind of go through some of the services that we're helping out with the organization and the community through this pandemic.
Yeah, and I know you guys have heard us talk about some of these things before, and I think really I'm just so proud of the whole organization. I think our response has really just been fantastic, and I hear that from our staff, I hear that from our providers, I hear that from my patients and people in the community. So there's a lot to be proud of. So we're gonna talk about some things we've probably talked a little bit about before, maybe expand on some of those. I like to kind of start with the respiratory evaluation station as kind of the heart of our pandemic response at this point. It was really important for us to have this one spot that had a really consistent message that people our community could reach out to, and that has been steady throughout the entire process. Not only are we seeing patients there that need respiratory evaluation, and allows us to kind of centralize that and keep our staff and our patients safer. But I think it's really been, instrumental in the message to our community that it's safe to come back into our clinics and our hospitals, because we really have been able to very effectively separate out those cases. Our drive-through testing center, I think I love to talk about this because I think it was just such a amazing turnover and how quickly we started this thing. I mean, we literally said, like, could we do that? We looked at a couple of videos online to see what other people were doing. And, now we have people reaching out to us in the region, asking us how we're doing it and what our process is. And it's really allowed us to just do the volume of testing that we're doing, which for a community this size is really high volume testing, and to do it in a really safe way. Our testing team is multidisciplinary clinicians, myself, Dr. Harris, Dr. Mattern, our operations team. We work with our lab. We work with our CFO, making sure that that everything we're doing for testing is clinically up to date. And I mean, this is a process that we are adapting. We meet weekly, and we're always talking about new things because this is just a constant moving target. But you probably remember when we talked about this earlier, all of our algorithms for testing that kind of changed every couple of weeks as the Department of Health and CDC were changing their recommendations. And and now we're thinking about making sure that we look at the newer technologies of testing and make sure that we are providing this community with really the best quality process that we can. And our medical case management program, which is really expanded and stabilized over the last few weeks, really. We've been working with the health department throughout this whole time, working with our care coordinators and case management team. But we've really solidified a process now to help be able to care for our COVID positive patients, again, in a safe way for our staff and to give them the support. And really this collaboration with public health, I think Dr. Locke will tell you is outstanding and really, the envy of many of his colleagues across the state. And then Jen's going to talk a little bit more about telemedicine in a coming slide. But this was something that I think we'd been wanting to do for a long time, and it was if there's a positive that comes out of this disaster, it's that we found a way to do it. And we really hope that. She'll show you some of the stats, and we were doing quite a lot of it at one point in time. We really hope to keep it as part of what we do going forward, and to provide that digital front door for people that's appropriate for.
Great.
Jen, you want to add anything on any of that?
Jen, you need to unmute.
Oh man, I'm sorry you had to say that to me. Yeah, just to go through some of the statistics of our team and the respiratory evaluation clinic through the week of 8/16, starting in the week of 5/31. If you see in the teal, that's our drive-through. The greenish color is our office visits within the respiratory clinic. And then if you look at the right-hand side of the screen there, these are just the overall visits to the drive-through in the office since we started in early March, and as well as our total call volumes, our inbound calls of 15,121 calls since March into our COVID hotline and a nurse hotline as well. So very busy group. We were staffing this with additional staff when we were low in the medical group and low in volumes and not able to bring patients into the clinics. Now that we are almost back to regular volumes in the clinics, we've had to hire additional staff to continue to staff the respiratory and the drive-through station. And with the drive-through is open 7 days a week as well. So with that. And then as Dr. Butterfield was talking about our telemedicine visits, which is great. So prior to the public health emergency, oddly enough, rural communities, rural hospitals, and rural health clinics were not able to provide and get reimbursed for telemedicine visits. So with that public health emergency, CMS allowed us to do that. And we're hoping that, and it looks like potentially that we will still be able to continue to provide that. Unfortunately, it's still not parity of cost for us in a rural health clinic as it is for other hospital systems. But there's been a lot of advocacy work by the National Rural Health Association. So hopefully we can get that figured out. But if you see on this graph, this is just kind of when we started telephone and video visits. And then as people our community started to feel comfortable coming back into the clinic. And as we were able to do that per direction of public health, most of our community feels good about coming back in. And we have about, anywhere from 7 to 10% of video visits per week. And those are people that it's just probably immune compromised, chronic diseases, that it's best for them to continue to isolate at home and provide care as well. And now that we are continuing to hardwire those items, we are starting to take an eye towards the future still and pick up kind of where we left off and how best to expand and grow services, specialty services for our community. And these are some of the services that we're looking at. Some of them are tied together with our master site plan and the work that we've done in terms of working with Jody to estimate market share in volumes and how best to staff, whether employer or partner, for these services. Currently, we are working with St. Michael's, or formerly Harrison, for pulmonology, infectious disease. We had a meeting last week with their ID physician down there are going to be able to provide some telemedicine services for us, both for inpatient and outpatient, which will be great. And then also really partnering with Dr. Meyerson as he continues to work and enhance our wound clinic, and really have an infectious disease partner as he goes into that service. We already, as you know, have a partnership with Harrison for our cardiology. So they want to bring up a cardiothoracic and a thoracic surgeon, one time a month or so for those patients that are having surgery in Bremerton, and so they could have their pre-surgery or surgical follow-ups here in our cardiology clinic as well. And then, so the last slide that you saw when we were together back in April 2019, we ended in this slide. And this was, okay, now we're all together as a multi-specialty medical group. And what are the things that we need to do to enhance the medical group and further our high performance as a multi-specialty medical group, and help prepare us for the world ahead of changes in healthcare. And so Dr. Butterfield and I shared that we had been looking at some various best practices and some organizations, and really landed on this kind of trajectory with the advisory board that we've kind of used to help shape and define the things that we want to do to help our team. And then, so we then took this information and we developed kind of our strategies for success that we have been slowly but surely working on over the last, year, half a year or so. And we did have the opportunity to go and speak at the AHA Rural Health Leadership Conference on some of those strategies that we're going to share with you today, which was quite the honor to share. And we got a great opportunity to really learn from our colleagues about what's working well for them and not working so well as well. So it was a great experience to present and share the great work that's taking place here at Jefferson Healthcare, but also learn from our colleagues.
I see a couple of our fans out there from Arizona. Thanks for coming back for our second performance.
Yeah. So these are the strategies that we have been working on that we shared at the conference. We're just kind of going to go through quickly some of these strategies, but we are going to take time and pause and really go through our dyad partnership and our recruitment and onboarding. And anytime that you want to stop and you want us to expand, we're happy to do this. Some of this information you already know, some of it is new, so feel free to stop us. So first thing that we worked on, and you guys are all aware of, which is why I'm here, and we talked about it at our last time together, was what the organization did in that organizational change that they made to bring on a medical group and help us kind of have our own reporting structure, because it's very different operating physician practices versus hospital operations, and understanding that difference, it makes a big difference in how that business is run and the culture that you can build. So this information here took place before I came, which is the reason that I'm here, to help lead the medical group. So anything you wanted to add, Dr. Butterfield?
Yeah, I just think, as I've said before, I think this kind of just helped our ambulatory providers to kind of feel less like a side project, and we had our own leadership team at the kind of senior leader table by developing our formal leadership roles in the clinics, and our medical directors, really gave some accountability and some influence to those physicians, as opposed to just kind of being a liaison to the administration, and really gave us this kind of tangible sense of trying to lead together, which I think has been really powerful.
Yeah, agree. And as Dr. Butterfield kind of engenders that sense of importance to an organization, which was happening around the country, where medical groups are kind of feeling not part of the group because everybody was starting to employ physicians. So that isn't something unique to Jefferson Healthcare. It's an evolving process throughout the country, and some of the similar stories that we heard from our colleagues in Arizona. And then our dyad leadership partnership was something that was on its way prior to me coming to this organization, which is, was at the time pretty cutting edge to take this leap and invest in this structure is really great. And it's there are many reasons why I'm here, but this is one of the reasons that I accepted the position, which is this ability to work collaboratively with a dyad partner, not only with Dr. Butterfield, but throughout the medical group and our organization. And I think it's just key, critical, and essential to us making the best right decisions for the things that we need to do for care for our community. And it helps align clinical and administrative leadership at every level of the organization, which truly helps us with collective decision making, reduces unnecessary friction, and helps us make the right decision and implement it fast, creates a really unified voice between administrators and providers, and it helps build trust as well.
Yeah, I always love to tell the story about Jen. You might have heard it before, but when I was kind of tasked early on with helping to find the right leader for that position, we felt really fortunate to get her CV, and it was really great talking to her. And I remember thinking like, yeah, this could be a really good fit. And she asked me at one point, well, how do your administrative team partner with your physicians? And I said, well, I think we work pretty well together. And she said, do you have a dyad structure? Because if you don't, I'm not really interested in coming. And thankfully I was familiar with those words, so I could say, well, yes, of course, Jen, we have a dyad structure, and that's what you'll be part of. And I think this has just made my role as a physician leader so much more meaningful to me, and I think to the organization. My experience before had really been, being part of physician leadership teams that really had good intentions and a lot of good thoughts and really smart, inspired people, but busy people with a lot of clinical duties. And we would kind of come back to the table our next meeting a month later and kind of be like, well, what happened since we saw you last, and kind of talking about the same things. And so really being able to kind of leverage Jen's operational and business expertise and really kind of move things forward. And I think she spoke of trust. I think the other thing that I always tell people, because I think people think that Jen and I always agree on everything, and we really we don't. I bring my own perspective to things. She brings her own perspective to things. Sometimes we have conversations about things where we just look at each other, nod our head, and say good talk, and pick it up again in a couple of days. But I think what we've done really well is to understand that the reason that each of us has those perspectives, and to really try to land on what's best for the organization, given both of our both of our expertise, and then when we leave this room, kind of speak with a unified voice. And I hope that my provider colleagues realize that when things kind of get put into action, that there's always been that provider voice as part of the decision making.
Excuse me, for those of us who don't understand dyads quite as well, could you explain a little bit what the dyads A and then B, C, D, et cetera mean? What does that really refer to?
Oh, yeah, sure. So if you just look up the top, so actually at a senior leader level, you have Dr. Mattern and Mike that work in a dyad structure. And then beneath that will be myself and Dr. Butterfield. And we continue that kind of dyad joint administrative physician leadership down into the clinic. So each one of the clinics has a medical director, and they have that same similar dyad partnership with the clinic managers.
And do those dyads report to you and Dr. Butterfield? So are they actually below in this chart, below dyad A?
Yeah, I don't say the dyad in particular, but like the clinic managers report up through Jake and through me, and the physicians and the medical directors report up through Dr. Butterfield.
So this isn't really an organizational chart. It just shows that there are dyads.
Yeah, and
Okay,
and shows that we kind of really cascade that structure and that mindset down through our operations teams.
Okay,
Yeah.
thank you.
You're welcome.
But we kind of trust, at let's say in this diagram in Diet A, we'll say that this is the one of our primary care clinics. We trust that although the clinic manager is reporting to Jake and the medical director is reporting to me, that the clinic manager and the medical director are working together to solve the issues and move things forward in that clinic. And if the clinic manager is reporting something totally different than the medical director is reporting to me, then probably we need to relook at that relationship, because we really want them to kind of work together at that level.
Yeah, I view it as formalizing the elevated role providers play in sort of the decision making here, where like that with respect to Jen and Steve, that nearly any issue, both on the clinical side and particularly on the administrative side, that decision-making process with the dyad structure now formally involves Steve's input and feedback, and the same is true at my level with Dr. Mattern. So it's like this. I think that the evolution of medical directorship, may have started 20 years ago, where you would name a medical director or chief medical officer kind of by name only, so you could point to as, yes, we had a physician in the room when we made this decision, to the point now where several times there are multiple providers in the room, and we don't make a decision until we reach a consensus. So I think it's a pretty powerful model, and I like to joke around by saying it's amazing how smarter we have become since we've went to that model.
Yeah.
Mike also likes to joke that sometimes when you give the physicians an ability to make decisions, that you have to listen to what they say. So.
Yeah, I didn't read that fine print presentation on dyads, but it's true.
And I would think we wanted to take a moment to kind of pause and go through this a little bit more in detail than the other strategies that we're going to go through here quickly. Because I truly believe that although we can continue to enhance our physician leadership program, I think it's one thing that we do really well, and it has become, I think, one of our competitive advantages. And I think that really came to light during COVID, as to having the physicians in the room, helping us make decisions and do the things that we need to do quickly and efficiently and effectively, has been just phenomenal, really. And that's thanks to our provider and leadership. So it's really great. And this just is a list of some of the things we do. But at the end of the day, we are all focused on good quality care, good value-based care, our patient experience, as well as our experience of our providers. And we can divide these out in great little boxes here, but in reality, sometimes those lines become blurred. Even as Dr. Butterfield and I are sitting down and looking at financial statements that Hillary sends out. So and then I'm sitting back trying to learn clinical processes and pathways to help us all be better at how we make decisions for those that we are here to serve. The next thing is just a shared vision. And this is one of the things that we did with primary care, and really spent some dedicated several months going through a strategic plan. As one thing that we're going to do as a multi-specialty medical group. We kind of took a pause as an organization were working through our strategic plan, kind of put that on pause, and we're now picking that back up again. And we will then pick it back up again as our medical group with all of our medical directors within our practices, as we will align our strategic plan and the things that we're going to focus on with our organizational strategic plan. But some of the things that we have done in the meantime, and have done even through COVID, just to keep us aligned strategically and from a vision perspective, is our quality metrics, aligning those and integrating those from primary care to specialty across the system, things that they continue to work on, being able to just partner together to implement new services help with some of the care redesign of delivery of care, even some of the things with COVID, alignment of the recruitment and onboarding process that was pretty solidified in primary care, and how we can then work with the specialist, and we kind of use kind of the same methodology, but that requires all of the medical directors and becoming part of that process. And then the physicians getting together some of the specialty groups and helping with some handoffs and referrals of certain patient types from primary care to specialty, and from specialty back to primary care. And those are things that they've been working on over the last year as well. And then care teams, and you can kind of look at this from a local level, but also from a group system level, and fostering that care team, in which we have done and continue to do in primary care as well, especially in that care team being a physician, advanced practice providers, nurses, your care coordinators, and how that team surrounds the patient to be able to provide great care. But we also look at it from a systems perspective as how those specialties work together for pathways, protocols, and transitions of care, and how they have that kind of a team fostered collaboration in from primary care and specialty to take care of our patients as well. And the next strategy is operational efficiency, and this is ongoing, never ending, and streamlining of processes, both at the local kind of practice level, from changes from scheduling templates to call centers to float pools to medical assistants, to streamlining the efficiency of how patients move throughout our systems on an ambulatory side. Once again, from primary care to specialty, back to primary care, back to specialty, whether that is the patient physically moving or how that information and communication is moved. One of the things that a project we're going to pick up that was put on pause is our referral process. And how we're going to partner with our clinical informatics team, our physicians, those are that are closest to the work, our referral coordinators, as well as our revenue cycle team, and how best to look at this to streamline this process for our physicians and our patients, with the idea of kind of a zero wait time goal as we move from referral off to actually making that referral into a visit and getting those test results back. And so, big project that we're going to be working on. And then the last thing, strategy we're going to spend some time in is the recruitment and onboarding. And so, Dr. Butterfield.
Yeah. So this is another strategy that we really wanted to kind of talk a little bit more about, because I think it's another thing that I think we're good at, and I also think is really essential to what we're trying to do here. And I think our tagline at Jefferson Healthcare now is fueled by our people, and so I think this is really some of the most important work we do is making sure that the people that are here are the right people. And we have this little saying, recruit to our culture, and what does that mean? I think there's probably lots of different ways you could define our culture here. I mean, you could look at our mission statement. I like to think of it when I'm talking to people. I want to find people that have a passion for taking care of patients, a passion for taking care of this community, and that it's important to them that we take care of each other here. And I think if we do those things, and it's also a qualified clinician, we're probably things are probably gonna work out really well. That being said, I will talk to people on the phone, and I might think that they are a perfect fit and a great candidate, and I never promise them anything, because I say, I think we have this great core of clinicians here now. We've got a great administrative team. When people come and visit us, we know whether they're going to be a good fit here, and so sometimes it looks good on paper, but it just doesn't feel right. And I think we've been fortunate to not be desperate. We've been thoughtful about our recruiting, even though we've grown a lot. And I think now we really are able to choose people that are going to be a good fit for our team. We have this other saying, always be recruiting. Sometimes we don't have a position available, but I'm talking to people all the time. Our provider recruiter is talking to people all the time. We're data driven in what we think we need, but we also keep our eyes open. And I mean, I think the two great recent examples are the two gynecologists and then our plastic surgeon. Those weren't things that we necessarily thought we were going to do, but when the opportunity presented itself, once we made sure that it was viable and that it was gonna help our community and help our clinicians take care of this community. We made it work. And this is a big part of my job. I try to have my hands on the recruitment process from we have a great provider recruiter. She hands me great candidates, but I like to talk to everybody before we do anything else. We involve our medical directors when we bring people on site. We have kind of broad touches across the medical group with from our clinicians to our administrative team. Mike likes to interview everybody, and I always think that is just such a powerful sign to the people that we're interviewing that our CEO takes the time to meet them and is engaged and but at the same time I think he trusts our decisions and so that kind of empowers us to keep doing what we're doing too.
And then one thing that we've also done is once we find the right fit, how can we help retain with our culture? And we've done that through over the last about year and a half, really revamping our onboarding process and knowing that it's just onboarding isn't just this one moment in time. It's really an ongoing process, much different than just an orientation. It's not an event, and it lasts, almost about an entire year for some people. But that helps us with assimilation into our organization as well as into our community, helps cultivate connections, build that sense of community, and help strengthen the culture. A lot of things that, depending on where the provider is within their tenure in their profession and how much of an onboarding process that we need, but we do have broad touches across the system to make sure they get connected with their provider colleagues, their administrators, so they know who to call when and know that they're always supported and that there is no wrong door for anything that they need. We've developed mentorship programs, training, and also a space to learn. Meaning that when you show up here, as much as we sometimes have to hold the door back, so we have patients that need to be seen, but understanding that they need that time to learn the system, learn the EMR. Sometimes if they're a new grad, just learning how best to go about practicing medicine. And having a physician mentor to help them along the way. So that's important because, we're not in it for today. We're in it for, as Mike says, for the long game. And we want people to come here and stay and be happy and flourish both professionally and personally here in this organization. So we partner with Allison and Jake and his team with the practice managers. And our physician leaders play a big role in that onboarding process. And the last thing that we are going to continue to work towards and strive to, probably after we go through some of our strategy sessions, is building our governance structure, which is different than an organizational structure. Our governance structure is, organizational structure is kind of like, hierarchical and who do you report to, et cetera, where governance really helps bring teams of people together to help kind of get the work done. It enhances collaboration, fosters clinical integration, helps to build even a fiduciary responsibility and obligation across the system. And it creates actions and results, and once again, helps build trust. And we have worked through a governance structure in primary care, so we're going to kind of start with that model and start to enhance it. And this is kind of the ideal governance structure that we would have throughout the medical group and how we would go about accomplishing, implementing our strategic plan, and how these are kind of the groups of the partners that we would work with, from clinical informatics to human resources to finance to quality. to help us do the things that we need to do to serve our patients and provide great care. And part of the thing about a governance, and it is truly what we call physician-led and professionally managed, which each one of these subcommittees will have a physician leader associated with that subcommittee and an administrative partner as well, in helping us accomplish the items that we need to get done. So next up, so a bunch of work still yet to do. And I just want to end with a couple of kind of measures of success. And one of those is from recruitment and retention. If we look at the number of providers that over the past several years that we have recruited, and then on the right-hand side, look at our attrition as that has significantly dropped off. So and the other one is retaining to our culture. And this is just a quick sneak peek. And I think Caitlin Harrison is going to come speak to you guys next month about some of the results from our engagement survey. So I won't steal a lot of her thunder, but I'll take a little bit of it. And this is just a quick peek at our survey of our providers in our medical group. And what are you really looking at? If you look on the right-hand side, you'll see a benchmark comparison. And if it's that teal color, that's good. And if it's that orange, these are opportunities for improvement for us. But if you see compared to those that are within our cohort of that survey, we are above the benchmark on many of our engagement scores as of this year. And then this is just a final graph that they show throughout the engagement. This is from your actively disengaged to your actively engaged percentile ranking. And to have 53.52% of your physicians actively engaged in your organization is pretty significant. So we're pretty proud of that. What are the other things from a quality care perspective? We just received our MIPS score, so our merit-based incentive plan, and these are our quality scores that we send. It's our quality information that we send off to Medicare every year, and oftentimes this does determine our reimbursement rate. And this 92.96 is compared nationally, so it's a national threshold. It's not just critical access hospitals, it's all hospitals that submit their MIPS data across the nation. And we got a perfect score of 45 out of 45 for quality improvement activities, 15 out of 15. Promoting interoperability, this has to do with referrals and closed loop referrals. So we have some work to do on that, but so does a lot of people around the nation. And this oftentimes comes to kind of revamping some of the processes within your EHR. And then even the cost of care, doing well with that as well. And then, we had to put in some bonus points. So, and just qualitatively, some of the information or some of the words from our team that we've heard over the last year and a half about what we're trying to build here and being a part of that, what we're pretty proud of. Just wanted to share some of that information. One of the ones that I always like to point out and do a humble brag a little bit is there is a provider that had worked here in the past and was talking about a paradigm shift has happened and I want to come back and work for Jefferson Healthcare. That just makes my heart melt that we can do that. And one just recently, which I thought was quite the compliment, is you've created a little kind of Mayo clinic here, which speaks volumes. I'm a big fan of the Mayo brothers and what they have built. So just want to share some of that with you. And then next steps. We're going to work through kind of our Be Well initiative as a team, and one of the things that we'll be working on as an organization, and you might hear some more about later. We're going to continue to focus on some of our process improvements, from pathways to protocols to handoff to referrals. Try to implement and get our governance structure off the ground, and work through our vision in alignment with the organization's strategic vision over the next 3 years. And I think we are 3 minutes over our time, but we're happy to take any questions that you might have or comments.
Mari?
Yes, 2 quick questions. Do I assume that Jefferson Healthcare is still doing 100% of the COVID testing?
I'm sorry, will you say that again?
Do I assume that Jefferson Healthcare is still doing 100% of the testing in our community?
I don't believe that we are. I think we are doing the majority of it. There are some tests that come through, I think, that public health is doing. Because as I look at the statistics on our site versus the public health website, there is still a difference in some of the testing numbers.
Okay.
But I would say we're doing the vast majority.
Yeah.
And the people that the health department identifies as contacts and the like are still coming through our testing.
Okay. And is that usual around the state, or that the hospital is doing it all, or most of it?
I guess I couldn't speak to whether that's usual.
Okay.
I think there are definitely places where you'll see testing, and other places where it is more public health driven. But I think
I think that's true. That in other areas there are multiple partners involved in doing the testing.
Okay, thanks, Case. And then the last quick question is, we're coming up to flu season, and you're already back to regular volumes. People need to get their vaccinations, their flu shots this fall. Is that going to put a bit more strain back on everybody, or?
It's
That's
kind of
probably
like
been
you're
anticipated.
asking the best questions, Mari, and kind of teeing up some strategies that we're already working on.
Right.
We are currently working on a drive-through vaccine, just
Oh,
like our
yay.
drive-through Quotic. Yeah. And
Yay.
so more to come soon on that. The Jake Davison and Revenue Cycle and facilities, they just met last Friday, and I think within the next week or so, you might see something coming out in that regards. Also, from our testing team, we are going to start talking about the strategy of testing, not just the vaccine, but the testing strategy between both flu and COVID.
Perfect. Thank you so much.
You're welcome.
And thanks for all this great, amazing work you guys are doing.
Oh, thank you.
Oh, thanks so much, Mari.
Anyone else?
Well, having worked in a clinic as a medical director with multiple clinics and other clinic directors, I really want to commend you on this remarkable organizational effort and the progress you've made. It's truly remarkable, and it's a difficult thing to pull off. And I think you folks have just done a marvelous job at it. So congratulations.
Thank you.
Thanks, Case.
Anyone else?
Great
Yeah.
report. A lot of good work. Thanks.
Thanks for letting us share it.
Well, I've got to say the medical group structure must have been a huge benefit during the crisis. And it sure resulted in outstanding response by all concerned. So thank you for all of your hard work. And I did have a question. You partially answered it with Mari's question, but I wondered if your strategic plan now is changing due to COVID. So it looks like you're doing some things with the clinics, as far as the ambulatory things and drive-up things. Anything else?
I'm sorry, are you speaking specifically about the organization or just the medical group in general?
Just ongoing strategic plan for the medical group segment.
Yeah, I think the most important thing is having good deliveries of care and ensuring that we have ample opportunity, or just various opportunities to serve patients in the time of a pandemic moving forward, and ensuring a safe place for people to receive care, and our providers and our employees and clinicians to give care. I think that'll be the theme that kind of encompasses all that we do in terms of our next strategic plan. And then from a clinical perspective, I don't know if you foresee anything else.
Yeah, this isn't necessarily a clinical perspective, but I think from one of the things that I think has really been underscored with the pandemic is how much people in our community, I think, would prefer to have their care here locally if they can. I also think that, as I kind of started the conversation talking about pandemic stuff, I
You'll
think
be back here when? 5 o'clock?
Yeah.
Case?
I think the response that I've heard from my patients and our community is really one of increased trust in what we've done as a whole organization over these past few months. So, I mean, I really think the opportunity to continue to grow our market share and make people feel more and more comfortable about getting all of the services that we provide here done locally is something we're really going to push for. Great,
thank you for all of your great work, and Mike for your part in it too. You really brought this to life, so thank you.
We owe a lot of this to the vision of our CEO.
Yeah.
The visionary leadership of our CEO, Steve.
Oh, sorry. I should have written it down, Mike. I'm sorry.
Great.
Okay.
Thank you. Thanks.
Thank you for the report, and you sure make us feel good now. So we'll go ahead and recess, and we'll come back at 3:30.
Yeah.
All
So
right,
I have a
thank
quick
you.
question.
Oh, go ahead, Matt. I don't see you on there.
Yeah, it was just I just saw this very strange thing this morning on the news about the CDC suddenly changing their guidelines for COVID testing, suddenly making it not necessary to test close contacts with COVID. I don't know if this is news to you. I was just curious, do we have to follow the CDC guidelines if they seem to be being manipulated? Because it seems they're accusing the president of wanting to just reduce the number of tests that we give.
Oh, I don't know about all the background to that. I did read the new guidelines, and I took it as whereas before they were recommending that testing, now they're not necessarily recommending it unless there are very specific close contact parameters met and at the discretion of a clinician or an organization. And I guess I would say for us, it still makes a lot of sense as long as we can do that testing with our low prevalence here, because it helps us contact trace better. So I don't anticipate changing anything. We've been following really the Department of Health guidelines, which I think we've tried to align with through all the processes, and they haven't changed their recommendations yet. So I don't anticipate any changes based on that right now, Matt.
Great, thanks.
Thank you again, and we will now be in recess. We'll be back at 3:30.
Thank you.
Thank you, everyone.
All right, great job.